Hi, my name is Kei Suzuki, and I'm a thoracic surgeon at Boston Medical Center. My colleague, Dr. Katrina Styling, a pulmonologist who runs the lung cancer screening program at Boston Medical Center, and I would like to talk about healthcare disparity in lung cancer screening. When we talk about healthcare disparity in general, we talk about factors such as race, gender, socioeconomic status, education level, primary language, where you live, and how these factors affect the healthcare that someone receives. This obviously encompasses medical care in general, and certainly cancer care, starting from screening to receiving appropriate treatment, whether that be for early or late stage cancer. Today we're going to focus on healthcare disparity in lung cancer, and specifically in lung cancer screening. One of the important initial goals is to raise awareness, and in doing so we hope it will lead to more research and more collaborative efforts across different disciplines, cancers, and institutions. Boston Medical Center is the largest safety net hospital in New England. We have 496 beds and provide care to more than 200,000 patients per year. More than 40% of the patients we see come from ethnically and culturally diverse communities, and as such, healthcare disparity is something we face on an everyday basis.
The topic of health equity is particularly important when it comes to lung cancer screening for a couple of reasons. First, we know that lung cancer affects patients that are Black and patients that live in neighborhoods that have been historically targeted by tobacco advertising. So it's important to extend this screening test to them to improve outcomes from lung cancer. The second reason that health equity in lung cancer screening is important is because it doesn't really make sense to only offer lung cancer screening to people that can pay for it or access it, because it doesn't change the mortality of lung cancer nationwide. Lung cancer is the leading cause of death in the United States, and it's something that we can change by implementing lung cancer screening on a population level for the patients that are most at risk. The disparities that we see in lung cancer screening, and similar to other cancer screenings and other diseases in general, I think are multifactorial. One of those reasons is that patients might not know about the test. Things like breast cancer screening and prostate cancer screening, you often see advertisements for it, they're in the news a lot, there's many foundations that are very active encouraging patients to get screened. But lung cancer screening is relatively new, and I think it's something where the word is just getting out to communities, and many patients aren't yet aware of the test. Similarly, I think some providers aren't yet aware of the test or aren't aware of the strong data supporting using low-dose CAT scans to screen for lung cancer. Other barriers, I think, to potentially eligible patients actually getting the test include things like taking time off of work, being able to come into their appointment, potentially being underinsured and not having the money to pay for their appointment because they're concerned about other things like housing insecurity or food insecurity. I think that disparities in lung cancer screening may also exist because we know that patients that are more at risk also have other medical problems, and that sometimes those primary care visits are spent addressing those other very important medical problems, and the discussion about lung cancer screening and tobacco cessation falls further down on the list of things to talk about and sometimes doesn't get addressed. Even when we identify somebody as being eligible for a lung cancer screening CT scan, sometimes it's still hard to get them to come in for the test. That can be because of the shared decision-making visit that's required prior to obtaining lung cancer screening. It's a separate office visit. It sometimes requires patients to take an extra day off of work. It requires the use of a decision aid, which can be challenging. These are printed materials with mathematics on them, graphs on them, and it can be challenging for some of our patients with limited English proficiency or literacy to understand those materials. I think another limitation once patients are identified as potentially being eligible, a limitation of them actually getting in for the scan can sometimes be the myriad of other medical problems that need to be addressed prior to talking about things like a screening exam in a relatively healthy patient.
When it comes to the issues we face in lung cancer screening, certainly the same healthcare disparity factors come into play, such as race and socioeconomic status. And I believe the downstream effects are twofold. Number one, safety net patients are at higher risk of harboring lung cancer. And that is because some of the known risk factors of lung cancer, other than smoking, so factors such as Black race, pulmonary comorbidities like COPD, personal history of malignancy, and family history of lung cancer are more prevalent in our patients. For example, Let's compare Boston Medical Center to the National Lung Screening Trial, the NLST population, which is a study that established the efficacy of lung cancer screening. By race, NLST had less than 5% Black population, where Boston Medical Center is 35 to 40%. Also, more of our patients have pulmonary comorbidities and family history of lung cancer compared to the NLST population. So number one, the safety net population may be at higher risk of harboring lung cancer, which means we need more emphasis on improving the screening efforts in this population. The second downstream effect is not only could they be at higher risk of lung cancer, they're also less likely to be screened, and this is well documented in the safety net population. To start to identify the exact issues, one of the first things we did was to review our own efforts. So we reviewed the initial 2-year period of screening to determine roughly what is our screening rate, meaning among the patients who seek medical care at Boston Medical Center and meet criteria to be screened, how many people are we actually screening? At Boston Medical Center, we estimate that to be about 16%. The published national data is in the range of 5 to 10%, and this is not to say that we're doing better because we limited our analysis to those with established care here. But the point is, however you look at it, 16% means there's a lot of room for improvement. The screening rates for other commonly screened cancers, for example, is much higher. About 70% for mammography, 80% for pap smears, and 50 to 60% for colonoscopies. So this goes to show that we have a lot of room for improvement for lung cancer screening. We then looked at what factors are associated with someone not receiving a screening CT. We found that even amongst our safety net population, Black race and lower income were associated with someone not being screened. The causes for this are likely multifactorial, such as lack of knowledge about the benefits of screening, lack of recommendation on the physician part, lack of trust with the health system or personnel, language barriers, or lack of access to care. Next, Dr. Styling will talk about what we are doing to potentially mitigate this disparity.
It seems like implementing lung cancer screening should be straightforward, but the reality is that there's many moving parts. And so you need to get the word out to the patients that they are potentially eligible. We made a point to engage our primary care providers, both located at Boston Medical Center and in our community health centers, to make sure that we were structuring the program in a way that worked for them. They really gave us some very important feedback, including the concern about managing these small spots detected in lung cancer screening. That really changed how we structured the program and really led us to developing this lung nodule clinic in parallel with the screening program. We involved the radiologists to make sure we had enough radiologists, enough CAT scanners to be able to do the scans. We involved hospital administration to make sure that we had the money to launch the program and the resources to be able to hire the patient navigator and nurse coordinator to help manage those scan results and to help liaison with the patients and their referring providers. Some of the other things that we've done to try to address barriers to lung cancer screening in the communities that we serve is we've gone out to educate patients and to educate community primary care providers about the availability of lung cancer screening and about the eligibility criteria. Another thing that we've done to try to reduce barriers to lung cancer screening is to make our materials, educational materials about lung cancer screening available on our website, and we include information in multiple languages for our patients. Another unique thing that we've done at Boston Medical Center to try to reduce the barriers to adherence to lung cancer screening is to develop a couple of subspecialty resources for both our referring providers and our patients. One is the Tobacco Treatment Center, where patients can be referred for help with smoking cessation. We have some excellent specialists there that are highly trained in helping our patients effectively quit smoking. The second is a lung nodule clinic, which is a subspecialty clinic aimed at managing patients with these small spots or nodules on their lungs that are detected by lung cancer screening. I have seen firsthand what an effective screening test this is, and I have seen so many lives saved by it. And I really want to find a way that we can reach more people so that they can have a similar experience and live longer because we're finding their cancers and curing them.